Good afternoon, and thank you for joining today's webinar. I am Judette Louis. I am the Department Chair of Obstetrics and Gynecology at the University of South Florida. I am also the current SMFM president. I would like to welcome everyone and thank you for joining us for this webinar on COVID-19 in pregnancy, an MFM panel discussion. It will be presented by Drs. Sean Blackwell, Torre Halscott, and Jason Vaught. Dr. Blackwell specializes in maternal-fetal medicine and has a clinical and scientific expertise in preterm birth, medical complications of pregnancy, the role of obesity in pregnancy outcomes, pregnancy in women with physical disabilities, fetal brain injury, and shoulder dystocia. He currently serves as the director of the Larry C. Gilstrap Center for Perinatal and Women's Health Research at UT Health Medical School. He is also the department chair and the vice chair for clinical research within the Department of Obstetrics and Gynecology at the UT Health Medical School. Torre Halscott is a maternal-fetal medicine specialist and a critical care physician who treats patients with high-risk pregnancies in the Baltimore area. He is an assistant professor in the Division of Maternal-Fetal Medicine at the Johns Hopkins University Department of Obstetrics and Gynecology. Sorry, that's gynecology and obstetrics. I forget that they flip them around. Jason Vaught is a board-certified maternal-fetal medicine specialist and a surgical critical care physician, also at Johns Hopkins Medicine. His focus is in the discovery of treatment and therapies for HELLP syndrome and decreasing maternal morbidity and cardiovascular diseases in pregnancy. Before we begin, I would like to take a moment to share a few housekeeping notes about today's webinar. This webinar is being recorded and will be available to view on demand from the SMFM website. Following the brief talking points, we will be asking questions of the panel members. You may enter your questions using the Q&A box at the bottom of the screen at any point during the broadcast. And in fact, I encourage you to do so as the broadcast goes along, because as you will see, we will stop in short periods and answer questions from there, as well as questions that we received from members of SMFM before today. Please refrain from using the chat feature to ask the panelists questions, and we promise to get to as many questions as possible during the time allotted. So with that, let's begin the webinar. We decided to hold this webinar because as we look around, we see that the cases of COVID-19 infection are increasing. This is a graph that shows the trend of COVID-19 infections worldwide, and we see the continuous increase in the slope of the number of new cases that are occurring. And in this picture, what we see is what's happening in the United States. And so it's tempting for people to say it's a second wave, but what this graph shows you, it's not a second wave. It's still that first wave that we failed to completely decrease the number of infections. We had some decrease, and then with reopenings, the increase in infections started occurring again. And so this is sparking a lot of concern for what this means for the healthcare system. I like this graph because it takes it state by state to see what is happening in each state. And so this is a graphic that looks at new cases and what's happening with new cases. They have a similar one for deaths, but let's just focus on new cases because we know deaths in obstetrics are rare even with COVID-19 infection. And so the panelists who are on today, are in states. I'm in Florida where we are seeing an increase. We have Sean Blackwell, who is in Texas, where they're seeing a substantial increase. But we have Torre Halscott and Jason Vaught, who are in Maryland, and if you look over in Maryland, they're actually now on their downswing of new infections. And so we represent different pictures of what is going on with COVID-19. So with that, I would like to ask our panelists, we can start with Dr. Blackwell, like what are you seeing, what is happening in your state, and what are some of the operational challenges? We're particularly interested in Texas because you are on the news, where there are rumors of hospitals really being overflowed with cases of COVID-19. Is that translating to where you are and to the pregnant population?
All right. Well, thanks, Judette, for the opportunity to share, and thanks for SMFM for doing this. I think it's always useful to hear other people's insights and things that are going on. So the state of Texas is being challenged right now. In particular, the major cities, Houston, Dallas, and San Antonio. I'll speak to Houston because I'm obviously pretty familiar with what's going on. Is our department has a relationship in maternal-fetal medicine and is a hospitalist program across 8 different hospitals. So we're providing MFM care both in a tertiary care like a level 4 center, but also across the city in various level 3 and level 2 centers. What's happening now are 2 big things, I think, that affect obstetrics. First is that the hospitals are getting really full with COVID positive patients that are sucking up medicine beds and ICU beds and attention and resources. And that's a big deal just because it affects the overall operations of labor and delivery. Even if our patients are not nearly as sick, there's a fixed amount of resources in the hospitals going to the operating rooms, dealing with PPEs, priorities for problems. So with the other parts of the hospital on such crisis, the priorities of maternal-fetal medicine or general obstetrics are more benign situations go down. In addition, because of the age of our patients, fortunately, I think more of our patients are milder. So there can be at times where our pregnant patients, are kind of put in a different category when you're talking with ICU people or critical care folks that are dealing on a moment-to-moment basis with having to make really hard choices about ECMO, medications that are available, very aggressive therapies, versus the majority of our pregnant patients that may have milder disease. So we're, as leaders and as clinicians, we're having to go back and forth with those particular issues. What's happening to us now as part of that is that, we're losing some space in the hospitals. A lot of, and I know it happened in New York with some of the hospitals where there was such a bed need for COVID positive patients. Some women's floors lost beds that had to be converted for non-pregnant patients. We've got a couple of our community hospitals that are undergoing that challenge in losing our postpartum floor, such that, those 18 beds or 20 beds or however many beds that are dedicated to postpartum now have to be used for a COVID medicine floor or a COVID ICU. So we're having to try to continue the same throughput on OB and MFM just with the LDRP model on just labor and delivery, as well as deal with all the other challenges that we're having in the COVID world. So that's number one, I think, the big issue at the hospital level. The number 2 big issue that we're seeing here in Houston, and it's least as it's affecting our department and our obstetrical units, is the toll and the impact it's taking on our teams, on our healthcare staff. We've got a good number of nurses, medical assistants, physicians that are developing illnesses, and we all have to have a really low threshold for taking them out of work. So they're undergoing tremendous stress on a personal level of what's going to happen with their health and how it affects the rest of their family if they're gonna expose their kids or their parents, and then they're coming out of the call pool, the clinical pool, the other things. So we're having to deal with sicker patients and deal with these things with less people, and a portion of our team is out on a continuous basis. And even if they're COVID negative, which the overwhelming majority of people are, fortunately, that are being tested, it still takes a psychological toll, a wellness toll, and then a toll when they're out on how we cover our units and take care of call and don't try to put too much burden on everybody else. So I would say those are the two biggest issues, that if you're going to be in a place that is going to get a version of a surge or increased testing related to COVID, you're going to have to figure out how to address or solve those two big buckets of problems.
Okay. I 100% agree, because we're having some of the same issues here in Florida.
I bet.
Just to move on to some other questions that that we were asked before this webinar, you know, if any of you can comment, we can start with Jason. If any of you can comment on, you know, what are you doing for testing? Are you guys doing universal testing? If so, how are the partners of the patients getting tested? How are the patients getting tested? Oh, you're on mute.
Sorry. So yes, that's a great question. And again, thank you for this opportunity. At Johns Hopkins, we are doing universal testing for all women who are admitted to labor and delivery. So that would include women that have preeclampsia, premature rupture of membranes, coming in for their scheduled induction, coming in for their cesarean section, coming in for observation. Now, in saying that, we do have the capability of doing RNA testing or rapid RNA testing or point of care testing on our labor and delivery. So we do get the results back within 1 to 2 hours. And so when they come in, they are treated and put in specialized triage rooms as persons of interest. And that's, again, if they're asymptomatic. Clearly, if they are symptomatic, then they would still get that rapid test, but we may put them on our COVID biocontainment unit instead of in triage. So there are different levels to that. When it comes to patients that are just coming to triage, just say a woman who's 38 weeks, thinks she's having some contractions, rules out for labor, she herself is not getting tested because she is not getting admitted to labor and delivery or going to the antepartum unit. When it comes to the partners, we are doing symptomatic screening for partners, but we are not testing partners. If partners have symptoms or if they do screen positive, we do have a way to get them tested. Also, too, if a patient is asymptomatic and test positive by our rapid screen, we do have an infrastructure to get partners tested and to get family members tested that are within close proximity of the patient.
Okay. From our perspective, now what about, because we're seeing a large onslaught of people who now are positive, Sean, has that impacted your ability to get your testing back quickly?
Yeah, testing remains a challenge. You know, all the hospitals have a fixed number of, at least in our system, are being challenged with a fixed number of rapid tests that they're able to do for various reasons. Access to the kits, reagents, other things. So, you know, we're doing universal testing in obstetrics, and we're trying to have a very fast testing for our healthcare workers, but it's not perfect. It's not what I would want. I would love for any of our healthcare workers that get sick or have symptoms to be able to get a rapid test and have turnaround on that day, but that's not happening, very rare, and it's not happening for us, and it's not happening for very many people. I wouldn't say that we're close to being able to do testing for partners at all. So, I mean, that's kind of a major gap that we're having in our systems, and then it's affecting how we manage our visitor policies for antepartum unit, postpartum unit, labor, the NICU, all those things. So, and if we had that access, I think we'd be able to be a little bit more liberal with visiting, because that's the other major stress that's happening, is a lot of our patients are, you know, without visitors as they're navigating through their healthcare related to our service line.
So we're finding, you know, we started off with universal testing a while back. I don't remember the exact date. And at first we were able to get a rapid turnaround. So within 4 hours, our patients who were admitted, we would have the test result. But now, and also in the beginning, we and within Florida, they said, if you want a test, you can get a test, whether you're symptomatic or not, even if you're just concerned. And so for a period, that was the policy. But now what has happened since opening back up with a rapid increase in cases, more and more people are getting testing. And so now all of the lab systems are overwhelmed, such that they're sending the labs out of state. So now even our inpatients, we've now had to tier them and say, which ones we can wait 8 hours to get a result on, and which ones are more urgent to get within 4 hours. Testing for healthcare workers, which used to come back same day, now they have to wait 2 days maybe to get their results back. So definitely the surge that we're seeing is impacting even the processes that we thought we had in place when the volume was low. And so I think that's an important concept for everything that you're talking about, whether it's the clinical pieces or the operational pieces, that just because it worked when, last month doesn't mean it will work this month, which makes it hard to plan.
Right. And I completely agree with everything that you said. One thing that we've kind of found with the point of care testing, and again, with point of care testing, there's a lot of quality and safety control issues that have to be overcome before implementing it. But we have been able to do that and been successful with it even afterwards. We'll see what happens if we do get a second wave. But again, like it's a tiered structure. So for instance, on L&D and in trauma, they may get point of care tests. However, when it comes to elective surgery or even healthcare workers, they would get their turnaround within 24 to 48 hours. So I completely agree.
Okay. How are you guys communicating outpatient results with the hospitals? That's another issue that has come up from our members, that they're concerned a patient may test positive and then show up on L&D 3 days later, and no one knows that they tested positive.
I can, we're doing a heck of a lot of tests now, so it's something that's getting built into our regular operations on a frequent basis. So, some of the things that we're doing is that we just built the aspect of COVID, whether they were tested or not, their test is pending and what the results are, into all of our handoffs, our safety rounds, our lists, everything else in our communications. So. We are doing outpatient testing for our scheduled births. So, if somebody's going to have a scheduled induction or a scheduled C-section, they're getting tested 3 days, on average 3 days before, and before they can come in for their delivery, we call them. So somebody's got to physically check that test, confirm the results, and then talk to the patient before they are able to come in. So that's one aspect of the testing. The other part of it is that we've just got that into our list and we're following things up. In the hospital on OB, the majority of our tests are the rapid tests, so it's a little bit easier to hold on to those and get that information. So if we're doing testing on all of our admissions and rapid tests on anybody that we think is going to deliver quickly, has a high probability of going to the NICU, or has some other higher risk status. And we're doing that until we're told that all of our rapid tests aren't available. Right now we're in a process where we're able to do that with the rapid tests. So our rapids are coming back usually somewhere an hour to 2 hours. So oftentimes, we're keeping those patients in isolation, not being aggressive with them, not moving them here or there until we've got the results back. Holding them in our OBED if we can before we move them to labor, so that we could move them over to a different isolation room if we have to. So those parts are easier. It is a challenge, tracking down these tests for patients that are getting tested.
Okay, I think
he might have froze.
Yeah, he froze.
In the outpatient area, they have symptoms down, but you just have to track it like it's essential information.
Jason, do you guys have any substantial volume of patients who get their care outside of your system?
That would be a yes. So I think sometimes, especially in cities where there are a lot of hospitals within a demographic area. I mean, I can name 4 off the top of my head. Sometimes patients use the hospital, the inter-hospital system as one hospital. Luckily, we do have, many of the hospitals in the Baltimore area do have Epic, so we can get into patient records using Epic Everywhere Care. Also, too, we do have a CRISP system, which allows us to look at a lot of the hospitals, not only in Baltimore City, but in the state of Maryland. So we are able to get access to records, and we may be able to see that a patient was, let's say, at another hospital in the state of Maryland 3 or 4 days ago. And if we have concern that the patient may have had testing at that time, we can reach out to that hospital. But yes, we do see that patients can sometimes go from hospital to hospital, sometimes intentionally, sometimes not intentionally. But luckily, we do have those systems in place, and we try to maximize those systems in place.
Okay, great. Some inpatient dilemmas. For those who are doing universal testing, what do you do with patients who refuse to get tested? And so that's been an issue that we're encountering more frequently. Other questions are, if someone's admitted antepartum, do you repeat the testing at any point? So your PPROMer who's there for 6 weeks, should we be repeating the testing? Do you have any recommendations for hospital workflows regarding testing partners? So let's start with some of those inpatient antepartum type questions. Did we lose Torre Halscott?
He's with us.
Oh, okay.
You can't get rid of me that easy, Judette, you know?
You needed a personal invitation? So Tori, if you wanted to take any of those questions. First, how are you guys treating patients who refuse testing on admission?
Yes, so
commonly we're actually not seeing a lot of patients.
We're not seeing a lot of patients that are refusing it on admission. So we haven't run into that dilemma, luckily, and hopefully that will continue to be the case. And I think Jason and I were talking about this the other night, not only from a pregnancy standpoint, but from an ICU standpoint. We really haven't hit that snag, and hopefully we won't. If we run into that, the policies, we're treating them as persons under investigation, and certainly if they have any symptoms, treating them with a high index of suspicion for being positive or any significant exposures, and taking those extra precautions for our personnel, obviously, as well as for the patients and everyone involved in their care. And then hopefully revisiting that and having the ability to test them at some point to be able to allocate those resources appropriately, and make sure that we all know what safety measures need to be employed for our care to be delivered to that patient appropriately. So that's where we're going. I said, luckily in Hopkins, we haven't run into that. I haven't had any patients personally refuse testing, from an ICU or from an OB standpoint. I've been covering antepartum and labor and delivery this week, and knock on wood, hopefully that won't happen from that standpoint.
So I've certainly
encountered testing. We haven't been exploring that as any sort of routine protocol. I would angle probably away from that personally. I think, if a patient has some, exposure and we admit them and they're asymptomatic and they test negative initially, and then it comes to light that, maybe someone at home prior to their admission ends up testing positive, I think then it becomes reasonable. Certainly if they develop any symptoms, it's reasonable. Or certainly we haven't had this problem and hopefully we won't either, but if anyone on the care team tests positive and there's that potential exposure, I think all those are, kind of as clinically indicated scenarios make sense. But as far as routine retesting, we have not been doing that. The only time we're doing significant retesting is a patient who has a convincing exposure, convincing story, however, tests negative initially, and then sometimes sending a repeat swab for them or even sending an antibody test for them. We had a patient recently who lived in the New York area, gave a history of having a positive antibody test a month or so ago, and had tested negative by swab for us on admission for an unrelated condition. We tested this patient actually a couple times just to ensure that that was still a negative from our standpoint because they had a convincing history, and sent antibody testing on them, which has not resulted yet. And that's a different dilemma of how persistent are the antibodies, how good is the test at detecting that persistence, and what the time frame is. So I would say probably looking at the clinical scenarios and retesting as indicated makes the most sense right now.
I would agree with that. I think another caveat that we have encountered is if there are exposures in the workplace. So one of the things that we are, some of the hospitals are experiencing is an increase in healthcare workers who are infected. And so with this increase in infections, they're getting them, most of them have been community acquired. But what's happening is that they are, a younger demographic, and so a lot more of them are asymptomatic. And despite screening, at the doors, we've had team members who come in and they're asymptomatic in the morning, and sometime during their shift, they become symptomatic. And so that would be the only other caveat, that then I think if an antepartum is being managed by someone who then, becomes test positive, then they become an exposure and they get treated as such. But other than that, I think I agree that once they've tested negative on admission, not necessarily repeat it unless you have an indication to. As far as those who refuse testing, we also treat them as PUIs, particularly if they have anything at all that is remotely suspicious for symptoms. But what's been interesting is that we were starting to see an increase in people refusing testing simply as it relates to some of the policies about visitor policies and what happens in terms of separating the mom and the baby. And so one of the things people may want to consider is making sure that whatever policies you have are consistent and do not create a incentive to refuse testing, because it sort of defeats the purpose of offering universal testing. And so that is one consideration. Sean, question for you about postpartum. One of our members asked whether you have recommendations for scenarios where the mom has tested positive and they're post C-section. Is there any particular type of monitoring? At this person's particular hospital, ID was recommending that all positive post-op patients go to the ICU, which sounds like a little bit of overkill to me. It sounds like they have ICU beds, but any of you can comment on post-op management and where that patient should recover.
Sure. So I want to mention something that we were talking about a couple minutes ago, because I think it's really important to emphasize. And with the beginning of the year being July, with the new set of trainees and faculty coming in, one of the reasons we're doing universal testing is in order to protect our healthcare workers. And there can be a time when some of our physicians are letting their guard down with a negative test, making the assumption that, well, I don't need to use all my PPEs and I can conserve this and I can conserve that. But, we're trying to really emphasize that, a negative test doesn't, it means that at a point in time, 3 days ago or whenever the test was done, the patient was negative, and that can change. We've certainly had some patients that came in for a scheduled delivery, were negative in the outpatient, and delivered and turned positive after becoming a PUI or something else. So, I'm trying to make sure that our trainees and everybody uses their N95 masks for deliveries and their other PPEs for deliveries and care, regardless of whether a patient's positive or negative during the care, during our higher risk intervention. So I just wanted to mention that. In the postpartum period is area, to answer your question, is messy right now, because I think we're all just making it up based on what we think is the balance between common sense, clinical judgment, resources, and trying to do different things. Because we definitely have some tensions. We can't, for moms that are COVID positive, that are asymptomatic, some of our hospitals are allowing moms and babies to be together, whereas other hospitals are wanting to have that separation. Some of our hospitals are wanting people to be able to have a visitor, say it doesn't make a difference since they're already positive, and other hospitals are trying to not allow visitors because of the perception that that may increase spread to the other healthcare workers or something else. So there's a lot of moving parts here because I don't think there's great information. If we've had a couple of our hospitals where if mom is known COVID positive and is entirely asymptomatic, we're more likely than not just keeping them on the postpartum floor and doing routine care. We're not, you know, they're isolated. We're using our appropriate practices, but we're not doing any additional antibiotics, therapy, anything else. We're treating them as routine with their other conditions as long as they're asymptomatic. If they are symptomatic and they're having a C-section or they were requiring oxygen or other things, they're oftentimes getting moved over to a COVID medical floor or medical surge floor off of labor and delivery because they were going to be separated from their baby anyway. And then that helps our capacity with our number of isolation beds that we have for our pregnant patients as well as for everybody else. So more often than not, we're sending those mild patients off of our floors until they get better and then they come back. If somebody is really, really sick, we're trying to have a low threshold for getting those patients to the ICU as long as the ICUs have capacity. And again, more often than not, really sick in our OB patients or our postpartum patients is not really sick to the patients that the critical care physicians are seeing. So, you know, there's some tension back and forth. We can't have our patients taking up beds where sicker patients need. So we're kind of, it's a little bit fluid depending on capacity, depending on what's going on, and depending on the individual hospital on their general approaches. And in our system, the hospitals are doing things a little bit different because they each have different leadership. I would encourage us to write things down so people can keep track of what it is that you're supposed to do if you work across multiple hospitals like we do, and you have to talk to different services, so you can remember what it is that you're supposed to do, and then remember when things change, because that's the other part is our protocol from last week is oftentimes very different than what we're doing next week in this evolution of care.
Okay. Just a few comments from the members who are watching. One person asked about testing, that they've also noticed that tests are taking longer. Their practice has been to try and preserve rapid testing by doing the send out drive-through screening for planned admissions. Now the results are taking 5 days. They used to take 48 hours. And so their question is, if you have a negative nasopharyngeal PCR for COVID in an asymptomatic admission, how long after the test can we be reassured that they are still negative, right? So can you really be reassured that 5 days later they're still negative?
So I think the thing is that I think we have to delineate testing symptomatic individuals versus testing asymptomatic individuals. For the PCR test, I think it's a little bit difficult because it seems like every hospital system has their own PCR, right? Even if the hospitals are within the same city. So I can speak to ours. For our symptomatic individuals, PCR, the sensitivity is kind of boasting like 85 to 90%. However, that's in symptomatic individuals. And that means that if the person is positive, they will be positive within either 2 days of starting symptoms or 7 days after symptoms. So if they're symptomatic, they should be positive for at least that 9-day interval. We don't really know for asymptomatics, right? Because we really can't gauge what the positive predictive value or the negative predictive value is. So I think, what Dr. Blackwell was saying earlier is even if you have someone who's negative, take the proper precautions, wear the proper PPE, everyone has it until proven otherwise. I guess the proof is, going back to the original question of when do you retest? If you've taken that, if that patient if it takes 5 days for the test to come back and they're negative, I would say, you wouldn't necessarily need to retest them, but I would, on the safe side, I don't think there's any harm in wearing the proper PPE to protect yourself and your healthcare workers. But I don't think the data is really out there.
Yeah, I've heard of it. Oh, go ahead, somebody else, I'm sorry.
Okay. Another question from the Q&A. One of our members asked, well, what about symptomatic spouses and children of healthcare staff and physicians? They should be able to get testing with a 24 to 48 hour turnaround time. That providers work with patients, hospital, and clinic staff closely every day. This additional anxiety runs high among providers when unsure whether their symptomatic family members are in fact infected, and they themselves are vectors that pass it on to them.
Yeah, I think, that's obviously a significant concern for all of us that are bringing potentially things home to our family, not only before COVID, but during this time. And it was a lot of the issues that we were seeing here. We weren't hit as hard as New York and New Jersey, obviously, but here in Maryland in the Mid-Atlantic, we're just a couple hours south of there, and had a large peak in the last few months. I have two young sons, and also my a little bit older mother lives with me, so being mindful of all those things was a challenge, and I think having a low threshold to encourage testing for anyone who is symptomatic, and seeing what their results may be, and then being good stewards of taking care of our patients. And if we've been significantly exposed, it does make sense, I think, to be able to pull back from some clinical care and decrease exposures, as much as possible. We've had that happen with some of our ICU providers in the group that I work with within the Hopkins system, that either have been positive themselves or had close contacts that have been positive, and actually kind of pulled themselves out of the call pool for a little bit of time, and ensure that they're negative before returning to take care of patients, to minimize that sort of risk. Yeah, I don't know that there's a clear-cut answer, but I think more caution makes more sense, because we certainly don't want to be the people responsible for increasing those risks to our patients as we're trying to protect them from this illness.
I would imagine in part, whether you can get a quick turnaround time for the family members of healthcare workers depends on the system resources and what's happening in the area. But for sure, I think leaders need to know that that is a way to support their healthcare workers. There was a great article a while back in which they did the survey looking at what are the things that are creating anxiety and stress for healthcare workers dealing with COVID. And certainly one of them was the fear that they will bring the infection home, and then also not being able to identify that quickly. And so, so I think that's a very relevant thing that leaders need to think of. There's another question regarding universal testing. In which they asked, if a patient tests positive on L&D, how do you differentiate between those who have a new COVID infection versus prolonged viral shedding from the index illness? Would you treat them the same as anybody else? Specifically, what would you recommend for mom and baby? We've had patients who have tested positive greater than 30 days from their initial infection. So that's a process thing. Do you guys have processes for dealing with patients who tested positive like a month ago?
So we do have some processes. I wouldn't say that they are infallible or that it goes for every patient. So let's go back to the original question of what do we do with women that could have increased viral shedding? So they had an infection a month ago and they're continuing to have these the shedding of virus. So one thing that we can do, and we have done in the past, is we can do antibody testing. So the ability to send off IgG, IgM, and IgA. So if they have, you would suspect that an IgG antibody would start showing up like at, after 3 weeks, but the IgM could still be around. That's one thing that we can do to help delineate it. So if the IgG is there and the IgM is gone, or the IgA is gone, that might make us feel a little bit more comfortable with the fact that this was a previous infection and this is just asymptomatic viral shedding. And saying that, we would still counsel the patient about separation of baby. We would still treat them as a PUI, but that would be a part of the counseling session. Another thing that we do is if we retest them for, let's say, for a repeat admission, it depends what the admission's for. Is the admission because, you know, they have chronic hypertension and they just need better blood pressure control, or is this an admission for delivery? And so at that point, we would say if the admission is not for delivery and they test positive and they're asymptomatic, then we would say we would probably retest them in another 2 weeks. But if they are scheduled for their delivery, then we would be more likely to treat them as a person of interest at that time. Because again, much like we've been talking about, we want to be what's safest as possible, not only for the patient and their families, but for, you know, our other healthcare staff and workers and our families as well.
So now some of our comments are creating anxiety for some of our members because they said, thanks, now we're going to run out of PPE, right? And so it definitely sounds like the where you can, the philosophy here, where you can, being liberal about the use of PPE, and some institutions just don't have that much PPE.
Yeah, and again, the comments are not to cause anxiety, but you know, I want to be honest and I want to be truthful with what we're doing at Hopkins, or what we're doing at other, you know, tertiary care centers. If you truly feel that the patient is asymptomatic and you feel like the risk of exposure is low, then, you know, perhaps you don't need to put on the gown and gloves. However, for all of our patients that we have, even in our outpatient setting, we are wearing a mask and a shield visor for our eyes. And I think that's the difference between each hospital system. Each hospital system is going to be a little bit different. So it may be that, you know, again, that you might not maximize all of your PPE, but I would still advise that, you know, doing the basic standard for your hospital system, which is whether that's either wearing a mask or wearing a mask with a visor for patients that are still having viral shedding.
Yeah, and to kind of add to that, you know, all our patients that are coming into outpatient as well as coming into triage or any sort of interaction as a first point, they're being asked to wear a mask as well. I imagine you guys are doing something similar and to try and decrease that risk of, you know, until we rule them out of any shedding or spreading of the virus they may have. So that's something we've been doing for a while. And then also to hopefully assuage some of that anxiety and to the audience as well as both to yourself, Dr. Louis and Dr. Blackwell, is, you know, we're a little bit maybe in the future from, you know, the outbreak that you guys are experiencing now. And we, you know, had that big swell of seeing a whole bunch of patients at once, and those same sort of concerns. Do we have enough tests? Are we able to allocate them properly and get them turned around in the right amount of time? Do we have enough PPE? And as these things work out, the system, you guys, you know, be able to figure out an efficiency to it. So that took us maybe a few weeks, to be quite honest. It felt like we were extremely well supported here from top to bottom, and had a lot of people having all hands on deck. And I know at your institutions as well. I would just offer that encouragement and hope to any other place experiencing an outbreak right now that figuring out how to make that workflow most beneficial for everyone at the bedside, and then also being mindful of the adage, you know, there's no emergency in a pandemic. Take the time to protect yourself, keep yourself safe, and take care of patients, and minimize those risks so that you can continue to take care of the most number of patients during this certainly very challenging time.
Yeah, this is an area where I get really fussy from a leadership standpoint, where, you know, we've got to be incredibly collaborative and in partnership with our hospital leaders, but it is not acceptable on any parameter for me to have any of the doctors that are under our guidance have to provide medical care with inadequate PPEs. So I lose my when I find out that somebody thinks that we don't have enough shoe guards, hats, visors when we're down doing sections or deliveries. And, you know, there's a stress, but it's the hospital's job to get this taken care of. And there's no excuse at this point in time, given everything that we know. Now, what I would tell you to manage that is that we build that into our huddles and our communications in order to get everybody a little bit more comfortable to know and to make sure that it's kind of checked off. So when we've had some hospitals run low on things or we couldn't find things, we escalate that up and then have the attendings check in at the beginning of the shift, you know, about shoe covers, hats, those sorts of things, or N95s. If you are a leader in maternal-fetal medicine at a hospital level, this is one of these things where you got to protect your people and really fight hard and be very loud about this, you know, so that folks aren't being stressed in the care that they're being given. I've certainly had to use hats for shoe covers. I certainly had to use the same N95 mask underneath my surgical mask for a while. And I think all places that are getting overwhelmed at times have to do those things, but that's really different than no PPEs. So you'll lose the confidence and the support of your team very quickly if they feel that you're not advocating for them, both nurses and your physicians, if we don't take care of that stuff.
It's excellent, and certainly, appreciate those efforts. Let's say, congratulations, keep those up. Keeping everybody safe absolutely is of paramount importance. Yesterday, we ran a simulation because we had some time where we didn't have a lot of patients, of bringing a COVID patient over for a stat C-section, and just to look at those things and say, where are the gaps where we could run into issues, not only from a PPE standpoint, but just from as simple as who's opening the doors, who's making this able to be as safe as possible for the patient, for the providers, for anyone who might be in the hallways, for our nursing staff as we move this patient from the LDR to the operating room. And we learned a lot of things. We've been doing this for a little bit of time already, and said, okay, here's some opportunities where we can change things and make things work better for our team, for the anesthesia team. So I know you guys are very busy with a lot of clinical volume right now, but if you have the opportunity to model some of this stuff and figure out where those other gaps are to augment that, absolutely.
A follow-up question to the question about testing positive 30 days out. So if someone can test positive 30 days out, then there's the concern about when are you guys returning patients to the outpatient office after they have tested positive? So in other words, someone's 20 weeks, they test positive. When's the next time they can be in your office?
So that's a good question. So for us, we for outpatient visits, they can come back to a non-COVID delineated office 28 days. So at least 4 weeks.
Wow.
We do have the infrastructure to have OBGYN staff COVID clinics or go to a COVID clinic setting where if a patient does have an urgent concern, needs a blood pressure check because she's near third trimester and has chronic hypertension, has an issues, needs a cervical exam, they can come to those outpatient clinics. Also too, for very urgent conditions, we have, again, a dedicated BCU. But in the outpatient setting, it's 28 days.
Okay.
And again, if someone is COVID positive, we only retest either on admission or if there are any other clinical concerns after that 28-day period. So to give you the scenario, if someone comes in, she has symptoms, has a cough, gets COVID tested, and she's COVID positive, if she's fine for the next month, we don't necessarily retest her again. She comes back and she can come back to a clinical setting in 28 days. And of course, we incorporate telehealth. So we will ask them to have a telehealth visit from home so we can check on them, make sure they're doing okay.
Sean, are you as resource rich as Hopkins?
Definitely not. But I think there's no right answer here, and we're all trying to find the balance of things. I mean, this is one of the tensions that we have because our offices and our clinics freak out.
Yeah.
With the idea of having somebody who has a positive test and then come in. The reality is we're not going to bring patients that are symptomatic and positive into the clinic. But even the asymptomatic patients, I'm getting pressure from people wanting a negative test before they can come in. That's probably not feasible in a lot of times, and some of these positive tests are going to linger. So we are trying to find a guide, and we're streamlining these questions through our director of ultrasound and some other champions in maternal-fetal medicine, such that a physician evaluates the medical necessity of that visit. We try to do something virtual if we can. If not, we bring them in. The reality is a lot of what we do in the outpatient setting is not life and death stuff. Do we do a fetal growth ultrasound on somebody just for BMI alone? Can we delay that scan when the EFW was at this 70th percentile before? Is it absolutely essential for somebody that is having antenatal testing due to chronic hypertension, not on meds, to just do kit counts? I mean, we can use some common sense and look at some risk adjustment with that. But I think strategically what we try to do is that we have a singular group of people or a singular person making these decisions about ultrasound, because then the faculty that's in the unit and the sonographers that are in the unit aren't the barriers to giving the care that we need. And we've confirmed that there's a true medical necessity for somebody to come in, and then we handle it internally, because the default answer to the doctor that's in the clinic will be no, hell no, I don't want a patient that has a positive test to come in for an ultrasound. Let's skip that. And some of these patients need care, but at the same time, we've got to find that balance. There is a rule of thumb that, and I apologize, one last thing is, there is a rule of thumb that people are using that if you're asymptomatic, if you've been 14 days since a positive test and at least 3 days without symptoms, your probability of being infectious is really, really, really low. Now, there's not data around that, and there's not a lot of stuff, but that's the rule of thumb that people are talking about here with the limitations of the testing that we have.
Yeah, a lot of places have been talking about following the CDC guidelines for when healthcare workers can return to work as a guide of when it could, because if a healthcare worker can return, then they cover that, then probably a patient can return to the clinical setting. We took a poll a while back, and most places were not using testing-based results to determine when someone can come back in the clinical setting because of the prolonged period of viral shedding, and without knowing whether that viral shedding is infectious or not. There are 3 other questions in the Q&A that I would really like to get to. So if you guys can just briefly answer, do you recommend antenatal testing for patients who have tested positive during the prenatal period? And piggybacking on that, are you seeing any increased rates of placental diseases like growth restriction, preeclampsia, stillbirth?
From our standpoint, we are not recommending antenatal testing for COVID alone. So still the usual obstetrical indications for outpatient testing, and we're consolidating some of our testing, as Dr. Blackwell was alluding to try and have those resources be matched and the exposures be minimized. And so going to once weekly NST with BPP, you're modified biophysical. And anecdotally, we're not seeing differences in adverse outcomes, and that's pretty consistent with, the data that's been put out there as well. So at this point in time, we are not increasing testing solely for COVID, nor, and hopefully continue to see it this way, not noticing an increased risk in adverse outcomes in our isolated COVID positive patients.
Sean, how about you guys? Oh, you're on mute.
No and no. I mean, I think we're trying to make things too complicated. If I don't believe that there's adequate data to test all these people, and to me, simpler is better.
It will be interesting when we get the data from the registry studies to see if we could make any sense of this. Members across the country have been commenting that they, anecdotally are seeing more stillbirths or miscarriages, et cetera. One of the things that will confound it, and confound that picture, and I look forward to sometime in the future us trying to be able to parse out the data, is to say, well, we know we've also altered care. So how much of what we're seeing, A, is it real? Can we prove it when we have large enough numbers? But then B, how much of that is truly COVID versus the fact that we've altered care for these patients where we're seeing them less frequently? Patients themselves are scared to come in. Locally we saw a stillbirth where, she felt decreased fetal movement, but she was scared to come in because of COVID. How much is attributable to each thing, and is it really there? So for, currently SMFM does not recommend any kind of surveillance just for COVID, but certainly I think you have to use your clinical acumen, the best that you can, and look at what other comorbidities the patients have. Another hot question from the members is regarding using anticoagulation. And that's a common question we get frequently. So are you guys using anticoagulation for for the patients who have tested positive for COVID? Does it alter based on, whether they're postpartum versus antepartum, et cetera?
Yeah, so for patients that are inpatient, that are COVID positive, we are using anticoagulation with sub-Q heparin. For patients that have shown that they will be stable or early in gestation and not require any neuroexo blockade or at low risk of delivery, we will do prophylactic Lovenox. We do look at other additional risk factors to see if we should go to intermediate to full anticoagulation. So some of those risk factors could be known family history of thrombophilia. Obviously, if they've had a history of a DVT and they get COVID, they may go from a prophylactic dosage to an intermediate or full anticoagulation. And then, of course, postpartum, after their delivery, we still do continue prophylactic, at the very least, anticoagulation, and we'll go up with additional risk factors. For patients that are outpatient, let's say a patient comes in, she has a fever and a cough, and she's at home, we generally are not starting prophylactic, intermediate, or full anticoagulation for those patients. Again, but we would look at any additional risk factors to see if that would change that. But for the outpatient setting, even after cesarean section or vaginal delivery, we are not sending patients or women home on any sort of anticoagulation unless it's otherwise indicated.
Anybody else, Sean?
Yeah, I have opinions about this. I think the data for anticoagulation is horrible related to this, and I'm very I'm gonna defer to anybody that thinks that that's the right thing to do with their patient population. I think the science and the data around it are bunk. I'm discouraging our people to give anticoagulation for COVID alone, but do it for the symptomatology or for the indications that we've had before. I think there's costs, there's unintentional side effects and complications related to anticoagulation that are meaningful, especially for our antepartum patients that are in the hospital and are getting anticoagulation that then are there for other high-risk procedures, and the anticoagulation can worsen some of the other complications they'll have related to bleeding, abruptions, medication side effects, other things. I look at the data and I'm pretty unimpressed. I think there are MFM people that love to treat and treat and treat and overtreat from a personality and from a regional basis, and that's just not us. And we'll see what the data shows.
So I will say this is one of the more controversial aspects of COVID management, is whether to anticoagulate or not, and then and then the duration, et cetera. And so, not surprising that we see the spectrum here on this webinar. Agree that the data is poor for it, and that certainly whether you choose to do it for isolated COVID or not, I do think it's important to take into account the whole patient and what else is going on in terms of their other risk factors for venous thromboembolism, and incorporating that into the decision making. We do have one question that goes back to the previous antenatal testing question, where they asked whether when we said no antenatal testing, were we also including no indication for a growth scan? I will chime in my personal opinion. Anytime you have an acute viral infection that we don't know anything about, I generally have a low threshold for growth scans, particularly if you cannot assess, fundal height later in the pregnancy. And so I think we speak with the caveat that it seems to me that people get scanned frequently and often, but there's some subpopulations for whom that's not possible. For me here in Florida, I have some of my patients at the federally qualified health center, and they come to deliver and they've had one scan this pregnancy, and I'm like, how is that possible? But it does happen. And so I think those are the instances where you would have to make a decision if you can gather the resources for a growth ultrasound later in pregnancy. Anybody else on the panel feel one way or another about that?
I think that's certainly a reasonable approach, especially, like I said, if they haven't had other scans during the pregnancy. It's been a bit challenging sometimes to have multiple growth scans for these patients. We're trying to be pretty stringent, with our indications for scans here within the environment of COVID. But I think, like all the things, if you have a clinical indication, then that makes sense.
I don't have a problem doing it. It's a low risk, low cost. It definitely does stress our ultrasound units and the stress related to our sonographers of bringing those patients in, them having to be locked in a room, with such close surroundings. So I would want the bang to really be worth it, the bang for the buck with it, which I'm not convinced. We're not routinely doing growth scans just because somebody's been symptomatic or asymptomatic with COVID. And the reality is the overwhelming majority of the interventions or tests that we do are probably unnecessary. And at some point in time when there's the rectification of value as opposed to productivity, we're going to get rid of all the stuff that we do, and we're going to be doing 50% of maternal-fetal medicine in the outpatient setting.
In a related question, one member is asking about, well, for those who have less resources, and don't have a designated extra COVID clinic, how do you take care of these patients who have very high-risk conditions, such as severe IUGR with elevated Dopplers, and they also tested positive for COVID? So how do you do that within the context of private practice? And I can comment. I'm not in private practice, but I comment as someone who partners with other practices in the area. And one of the things that was very important very early on was us reaching out to our referring providers and laying out some guidelines for what to refer to us and ways in which we can help. So basically, I would say if you have that capability of partnering with someone in the region who may have a dedicated COVID clinic. The other thing is sharing our guidelines with, making sure that when we update our guidelines or policies of what we're doing with COVID, making sure that we have a conversation with our private docs in the area and establishing that relationship. Obviously, that's something that you don't establish in these relationships. You don't establish in the times of COVID. These relationships almost have to be pre-existing that then, during COVID, they become a resource. But that's one option. The other option that we've had clinics who, they just can't, again, they can't have a COVID dedicated clinic, but what they've done is they've come up with a plan to say, okay, we'll take this certain exam room, which has the least amount of traffic, such that a COVID positive patient would not be going straight through the waiting room full of people and, decreasing the number of people who are exposed, set off in a corner, or maybe a room that's not used as much, and dedicate that room to being the room that where they see those patients and get all of their care. It's definitely more difficult because you have to put specific plans in place. You have to plan for that, for downtime for that room and for specific cleaning for that room and the equipment, et cetera. So it's a lot more difficult for the private person who has less resources. Another question coming from the members is whether your hospitals are considering labor to be an aerosolizing procedure, and are you using N95 masks during laboring and pushing if their admission test was negative? I think, Sean, you commented yes, right? That regardless of the testing results, you're having your faculty use N95s?
Yeah, I mean, prior to universal testing, it was a little bit different, but that was one of the major fights that we had, or I'll call it a discussion, related towards use of N95s with unknown asymptomatic patients. So if somebody is negative, we're not requiring people to wear the N95s, but if you've got your N95 for the day, we're issuing them on a daily basis and then recycling them We're just telling people to wear them routinely part of their deliveries and their C-section. So I do think that there's adequate data to suggest that the risk is a lot higher at delivery and C-sections. So you should wear an N95 with unknown status and a positive status for sure. And so I think I'm less stringent about negative patients. I don't know what others think with that.
Yeah, I think it's reasonable if they are an unknown status to wear your N95 and a face shield. For laboring patients that are pushing and for patients during C-sections, we don't require a N95 mask if their test has come back negative, but we leave that up to the application of the provider because we are like giving them their PPE and their N95s. But we would say for a pushing, at least have on a mask with your face shield visor for a negative patient.
Yes, certainly. I think each institution has their own rules, and some of it may be driven by the local resources, the philosophy of the leadership, and certainly the members themselves. Another question that was asked by the members, why is SMFM recommending full BPPs when we know the NST decreases risk because the sonographer doesn't have to stand there the whole time, that the patient could be put on the monitor and nurse walk away?
I don't know. I mean, I think either would be fine. I mean, I don't have a strong issue if people are believers in modified BPPs. It's fine.
Right, and I think it's important for the members to realize that people are presenting, just as we mentioned before, we're making it up in effect, really, because we don't have data to guide us. We're trying to take best practices that we knew in non-COVID days and apply them the best that we can, tailored to our patient population and our resources. And so what is presented here are not official SMFM guidelines. What we're presenting are personal experiences from people who are dealing with COVID within the healthcare system, and trying to provide considerations that you should think of when you're trying to make your decisions. Okay. We are over time, but I wanted to not leave without addressing the recent results of the recovery study. So the recovery study out of the UK demonstrated results that showed that dexamethasone was beneficial for patients who had a severe COVID infection. You guys, either Jason or Tori, address what it means for obstetrics. Should our patients be getting dexamethasone?
Yeah, I think the jury is still out on that. Certainly the preliminary data and the press release associated with it was very compelling and very interesting, but I want to see the full trial data and be able to look at that from that standpoint. Anecdotally, I do have some colleagues who have utilized it for some of our ventilated patients or patients requiring significant oxygen in accordance with the reported preliminary results from that trial. It's low dose dexamethasone, similar dosing that we would do for fetal lung maturity, which is extended over 10 days. So the risks, that have been reported in other studies looking at steroids in critically ill patients may or may not be the same, because it tends to typically be different, higher doses and potentially for more, protracted courses depending on what's utilized. So the short answer is, I'm not sure we know yet if our patients that are pregnant necessarily need to or could benefit from it, but I think it's a reasonable discussion to have for a patient who's pregnant or not, who is requiring significant supplemental oxygen or certainly mechanical ventilation, with the caveat that the full trial hasn't been published yet, and there may be some other information we can get once we see that full information that modifies.
Okay. Let's see. We're going to wrap this up since we're over time. We were able to get to most of the questions, not all. We certainly didn't get to all of my slides, which just says sort of the need for more of this. I'd like to thank everyone who joined us, and I'd like to thank the panelists for their time, SMFM members and beyond, everyone who's attended. Please remember that we do have our SMFM COVID site that has a lot of our webinars and our educational materials. We will have our updated guidelines for clinical management will be posted today, but this is the website where you can go to and find everything that we are offering. This webinar will also be posted on this website. You can find it under online opportunities for clinicians. Once again, thank you so much for spending your time with us, and we look forward to seeing you again with our next webinar. Thanks.
Thank you, Judette. Take care, everyone.
Bye.
Thank you.